Good evening, everybody, and welcome all of you to this live program at Orthopaedic Principles. Today, our guest of honor is Dr. Alvin Abraham from Leicester, United Kingdom. Alvin has spent 15 years on trauma and orthopedics frontline as a consultant and has recently commenced as head of service for trauma in Leicester. The highs and lows of working in the NHS notwithstanding, he remains a committed clinician, manager, and a trainer. Clinically, he particularly enjoys the challenge of salvaging infected, traumatized, and deformed limbs in his chosen field of limb reconstruction. His support of the marginalized has driven his enthusiasm for several interesting projects. This has included his advocacy of junior surgical trainees as training program director, the genesis of Foundation Doctors Program for international medical graduates, and the creation of a specialist orthopedic training program for late entrants into the NHS. Alvin is particularly proud of his role as a co-founder of the Leicester-Gondar Orthopedic Partnership, conceived in 2017. This is a partnership between the University Hospitals of Leicester, University of Leicester, and the University of Gondar in northern Ethiopia. If you've noticed, Dr. Abraham has delivered a lecture on our channel in the past and has already reached a huge audience. And today it's my great honor to bring back Dr. Alvin Abraham for this wonderful live program. Over to you, Alvin.
Okay, thank you, Hitesh. Thank you very much for having me again. And I'm particularly pleased to be talking about a topic which is of great interest to me and is particularly dear to my heart. I think most people in India are aware of the Ilizarov technique. They're aware of Dror Paley, who brought the technique from Russia to the West, propagated around the world, gave it a system, gave it a technique. So I'm particularly indebted to those two pioneers who've developed this system of limb reconstruction. And that's what I wish to emphasize, is that this is not a technique, it is a system of assessing orthopedic deformity. Just a disclaimer at the start, you know, if we were doing this in front of a live face-to-face audience, then I would like to interact. You know, I have this technique of asking people non-threatening questions, the Socratic method of making people think over a question, answering, and it would have been great to have done that in a different setting. And secondly, I'd like to emphasize the importance of knowing versus understanding. Knowing is when you have heard of something, you know some facts, and understanding is when you not only know it, you understand it, and you can put it into practice. I think it's really important to ask yourself, do I know something or do I understand something? If you understand something, then you're in the territory that you can put it into practice, you can use it for the benefit of patients, and more importantly, you can pass it on to the people that you work with. I'd like to kick off, if I may, with talking about films. I love films, and this is probably my best ever war film. And most of you will have recognized it as being Saving Private Ryan. Saving Private Ryan is a World War II film, and it's a World War II film with a lot of meaning, because a team of soldiers go out to rescue a soldier, Private Ryan, whose brothers have died in the war. So he's the only remaining son in the family, and the chief of staff of the American forces has ordered that he be brought back to his family, lest the family lose yet another son in the fighting. The bigger picture, however, is that when the soldiers get to Private Ryan and they're insisting on him on escorting him back to safety, he chooses to stay. And along with the group of soldiers who've set out to save him, he chooses to stay and to guard the last bridge that will allow Allied forces onto mainland Europe. So the Allies had landed in Normandy, and they needed this one bridge, crucial bridge, to get forces from the coast into the fighting arena. So that's the bigger picture. The smaller picture is that there's a group of soldiers who've gone out to save Private Ryan. The bigger picture, if you get to see the film, is that this group of soldiers ensure that the Allied forces are victorious by preserving access. And that's my theme about limb reconstruction. I'll use another example. You know, here's a bimalleolar ankle fracture. Many of you will be familiar about fixing this. And many of you will say, well, this is a fairly standard resident year 2, resident year 3 operation. But I wonder how many of you know that if you look at long-term outcomes of ankle fractures, then approximately 50% of ankle orifices remain painful at 5 years, 10 years, and 15 years. I wonder how many of you realize that in spite of perfect fixation, about a third of all bimalleolar ankle orifices will develop severe, life-changing osteoarthritis. That is the bigger picture with ankle fracture fixation. And if I may, that is something that's quite often missed by many people who think about limb reconstruction. So when I did a WhatsApp poll of what my residents thought of limb reconstruction, they gave me the standard textbook answers of non-union, infection, tibial fractures, etc. But very few thought of it in a wider sense. One nice answer I got was that limb reconstruction is about the 3 Ps: planning, precision, and perfection. Yet another couple of answers which I thought were very good were, again, getting to the nitty-gritty of limb reconstruction and deformity analysis, which is that it's about thinking about the mechanical axis of the whole limb from the hip to the ankle, and thinking about the deformity, how to improve it, how to optimize it. So that is the bigger picture of limb reconstruction. And I hope that at the end of this talk, whatever field that you might be involved in, maybe you're an arthroplasty surgeon, maybe you're a knee surgeon, I hope that you will take away the principles of deformity analysis and limb reconstruction, because I can assure you that your results will be better if you're able to appreciate. So for instance, if you're a hip surgeon faced with a non-union of a proximal extracapsular hip fracture, will you appreciate the importance of restoring the anatomical axis of the proximal femur? If you're a trauma surgeon, will you appreciate the importance of restoring the distal alignment of the femur? If you're a knee arthroplasty surgeon, will you appreciate the importance of restoring the anatomical axis and the mechanical axis when you do bilateral severe total knee replacements? And similarly, if you undertake, distal surgery of the tibia and the ankle. Just to qualify what I wish to speak about today, I'm going to limit myself to the coronal plane. This is a really heavy topic, deformity analysis, and it's easily it's easy to get muddled up with all the details and the angles and the numbers. So I'm going to break it down and say today I'm going to deal with specifically just the coronal plane. And by the coronal plane, very simply, I mean the alignment on an AP X-ray from hips to ankle of the femur and the tibia. What I'm not going to talk about today is the sagittal plane deformity, such as you might see here with contractures or a recurvatum deformity after growth plate arrest. And what I'm also not going to talk about today is the rotational alignment or the axial alignment, i.e. femoral neck anteversion, distal torsion, etc. We'll have to save that for another day. So I've organized this talk in a sequence of 3 workshops. So my first workshop is on the basics, the terminology of limb reconstruction, and I hope that you will become familiar with these terms. The second workshop will be mainly the drawing technique, the measuring technique of putting it together, and then the final section of this talk is workshop 3, where we will do a few practical cases to hopefully demonstrate the technique. So how about we start with workshop 1, and very simply, mechanical axis. What is mechanical axis? It's a straight line from the center of the femoral head through the knee to the center of the ankle joint. And the ankle joint could either be the center of the 2 edges of the talus, or it could be the center of the plafond, whichever you choose. But the center of the ankle, the center of the hip, should pass through the center of the knee. In real life, when you look at studies, you'll actually find that the mechanical axis passes very slightly medial to the center of the knee, but it passes approximately 8 millimeters medial to the center of the knee. So it's a very small amount. So for all intents and purposes, and to keep this simple and practical, most surgeons would use the center of the knee as being the site of the mechanical axis at that level. So just to confirm then, In the tibia, the anatomical axis and the mechanical axis are the same, i.e. the line that you draw from the center of the hip to the center of the ankle goes right through the tibia, just like you would do a nailing. So if you did a tibial nailing, you'd put a straight metal rod down from the center of the knee to the center of the plafond, and that would be an anatomical axis. So similarly, the anatomical axis and the mechanical axis for the tibia are the same. But as you can see from this diagram, the anatomical axis and the tibia and the mechanical axis in the femur are divergent, and that's because the femur slopes, doesn't it? So the center of the hip and the center of the knee on a straight line, but it does mean the piriformis fossa and the center of the shaft are in a slightly different plane, and that difference measures 6 degrees. So there's a 6-degree difference between the mechanical axis and the anatomical axis in the femur. Okay, let's move on to something else. So people are familiar with cora, but may I suggest a different word? May I suggest that you use the word apex of a deformity? So let's use this as an example. This is really very simple, isn't it? So PMA means proximal mechanical axis. DMA means distal mechanical axis. So on the left, you can see you've got a fracture with varus, and there's an apex where the two lines meet, i.e. there's a center of a deformity angle where the blue and the red line meets. And because I told you that the mechanical axis and the anatomical axis of the tibia are the same, if we rename them and call them the proximal anatomical axis, the distal anatomical axis in the tibia, that center, that apex is still the same. So the apex is the best word to describe the center of rotation angulation. So the center where two lines, the apex where two lines converge to give you an angular deformity is best described as the apex. And I will come on to describing what cora is and a few other terms. So that's the tibia. What about the femur? Well, the femur, as we've touched on before, is slightly more complex. Let's look at the image on the far right initially. So we look at the anatomical axis of the femur. We look at the distal anatomic axis of the femur. And when you have varus like this, the two lines will converge, and the center of angulation will be where those two lines converge. And then you can measure how much varus there is in this instance. Okay, it's worth, if you have time, typing these words in Google search, how the Ilizarov method came to the West, because it's a really nice summary by Paley of how methods that were perfected in Siberia were then refined after being transported to the West, after being propagated in the West. These ideas were refined and made into a scientific concept, which is what we all understand now, and which is what we can fortunately teach. So if I was to, again, use the Ilizarov technique of the apex, it would look like this. You'd have a tibial fracture, you would have a proximal anatomical axis and a distal anatomical axis, and where those two lines meet would be called the apex. And intuitively, the Ilizarov Russian Siberian surgeons would put a hinge at that apex, and they would distract it in such a way that they would then get perfect anatomical reduction, perfect alignment, and end-to-end compression for healing. And that technique was what Paley later understood, refined, and propagated in his method of deformity analysis and planning. And we have to be very grateful for his work in this regard. So if I was to say that there are 3 different techniques of cutting a bone and straightening it, then these are them. So if you have an apex of the blue segment and the green segment, then it would be somewhere along that black line. So that black line represents an axis. The actual center of rotation would be somewhere on that black line. But all the black line essentially represents a sequence of points at which you could get perfect correction. So that is what's called the axis of center of angulation, or the ACA. So the ACA permits you to do a correction as long as you put a hinge, or as long as you rotate anywhere along that axis. So on the far left here, you can see that the hinge is on the concave side, which means that when we do our correction, we get a closing wedge. When we put our hinge on the convex side, well, what do we get? We get similarly perfect correction, but we get an opening wedge, which means that we get length as well. So we've corrected the alignment, but we've got length as well. These two are called osteotomy rule 1. So when you perform a correction on the ACA, it's called osteotomy rule 1 because you've got perfect alignment with no translation. What happens, for instance, if you can't do your osteotomy at the ACA? So there might be instances when you have to stay away from a zone because the soft tissues are poor, perhaps, or you've got a flap, or you've got scar tissue. And so you need to choose a level of osteotomy distal or proximal to that zone of injury, in which case you now have to use what's called osteotomy rule number 2. So if you look at the far right, you will see that similarly, we've got perfect alignment, but because we have rotated on the ACA, but cut separately at a point distal to the ACA, we now have to dial in some translation at the osteotomy site, not at the apex site, not at the ACA, but at the osteotomy site. And that's really important to appreciate. I'll come to this later on, but these are fundamentally the 2 osteotomy rules that everyone should appreciate. Osteotomy rule number 1, when you do it on the ACA. Osteotomy 2, when you do it elsewhere to the ACA. So you have to dial in some translation. But the important thing to appreciate is that the alignment is the same whether you use osteotomy rule number 1 or osteotomy rule number 2. So here's another example of the same osteotomy rules that I've mentioned to you before. So we've got a deformity in a tibia. We've drawn the apex, which is the line between the green, the blue, and the red. We have a line which goes through the apex, which we can call the ACA. So you can correct this deformity by rotating it anywhere on the ACA. As I said previously, if you rotate on the convex side, you will get length. You will get an opening wedge. If you rotate on the concave side, then you'll get a closing wedge. You will get shortening. Let's see how that looks. So let's just concentrate on image number A on the left, and you can see I'm going to choose a point on the far left here. And by rotating on the far left, I can get length. Now I've got perfect anatomical alignment between the red and the blue, but I've got length. And if I do a similar osteotomy, and this time on the concave side, and rotate it on the concave side, I will get shortening. But again, I'll be able to correct the mechanical misalignment. I hope you understand that. So again, just to re-emphasize these concepts: opening wedge when you rotate it on the convex side, closing wedge when you rotate it on the concave side. You have to take a wedge away. Rule number 2, if you rotate it not at the ACA, so you rotate it at the ACA, but you've done your release, you've done your osteotomy at a different site. So it's still rotating on the ACA, but you can see you've got an element of translation at the osteotomy side, but not, and I emphasize, not translation of the mechanical axis. The mechanical axis, the blue line and the red line are collinear. Rule number 3 is not really a rule, it's really a mistake. And I'm just showing you the opposite, or the mistake that could happen in example number C if you didn't do the translation. So they've chosen the ACCA at the wrong place. They've chosen the ACCA at the level of the osteotomy. And what's happened is that you've corrected the angulation, but you've now created a translational deformity. Now, fortunately for the modern generation, those of us who do deformity correction, the hexapod does away with the cora. So the hexapod essentially allows our brain to be a bit lazy. We don't have to do all these complex drawings. We just have to dial in the deformity and the hardware settings into a computer program, and then the computer program does it for us, which is, you know, absolutely beautiful and wonderful. So the end of this section, I wish to emphasize that, you know, this is not about, this is not just a technique. It's a system. It's a system for assessing deformity at any level in the lower limb. So whether you're doing an operation at the hip level, the knee level, the tibia level, or the ankle, you should be familiar with assessing deformity, managing it, and correcting it. How you fix it is your choice. So here we have examples of a deformity which have been plated, and we can similarly show examples of deformities which have been nailed. And, you know, just to emphasize that once again, we're immensely grateful for to Draw Paley and Herzenberg and other people who have refined this technique and have made it a system which is reproducible in whichever field of orthopedics that you practice. So I think this would be a good time, if you're watching this as a replay on YouTube, it would be a good time to pause the video and to go back and revise these concepts of the mechanical axis versus the anatomical axis. Understand what's the apex. The apex is crucially the intersection of the two segments of a angular deformity. The axis, ACA, angulation correction axis, is a line that goes through the apex, and the cora, center of rotation of angulation, is any point on the ACA line. It's really important that you understand these differences. Understand what the osteotomy rules are, rule number 1, rule number 2, and, you know, repeat to yourself and understand and assimilate that this is not a technique, it's a system of assessing the lower limbs. So having done workshop station number 1, we'll move on to workshop station number 2. And in this section, what I'm going to emphasize is the complexities, especially of assessing deformities when it isn't a straightforward diaphyseal deformity. So you can imagine if you have a diaphyseal deformity, such as this on the far left, you can draw an apex very easily, can't you? And you can draw an apex very easily because you have two diaphyseal bisector lines which intersect beautifully and give you an apex deformity with multiple coras. Similarly, if you look at the tibia with the angulation in it, this third diagram along, you can see a bisector of the proximal diaphysis. You can see a bisector of the distal diaphysis, and they make a nice, neat intersection, a nice, neat apex with multiple coras, and then you can draw the ACCA, and then you can work out how much angulation you need to correct with a nail. But what if your deformity is close to a joint? What if your deformity is somewhere where you haven't got an anatomical axis that you can readily identify? So look at this femur here, the second femur here with a query DAA. It's very easy to draw a proximal anatomical axis, but where would you draw a distal anatomical axis? Similarly, in this tibia here, it's very easy to draw the blue distal anatomical axis, but where would you draw the proximal anatomical axis. So this is the conundrum for which we have to be grateful to Dror Paley for the work he's done in giving us reference angles. So for instance, this femur here with the query DAA, what we need to do is draw some kind of reference angle from a population average, which will then intersect with the red line. And similarly here in this far right tibia with the query PAA, what we need to do is draw a reference angle in the proximal tibia, which will then intersect with the blue line and give us an axis, an apex, multiple coras, and an ACA to correct the deformity along. Just in case you were wondering, what this means, I wonder how many of you play snooker or play pool. And there are sometimes in pool you'd like you haven't got the option of a straight shot. You have to pocket the ball at a bit of an angle, and so you're only left with being able to do this if you angle your cue or the stick in a slightly different angle to get the ball in the correct the ball in the pocket. And so here is an example of you having to use a reference angle or a reference line. And similarly with periarticular deformities, we have to create a reference line, then use the diaphyseal anatomical axis to then determine the apex and the cora. So here are the reference lines that we've been blessed with by Paley's work. So we can create a mechanical reference line, and this is accepted to be a 90-degree angle between the center of the femoral head and the tip of the trochanter, and this is the upper end of the mechanical axis at the femoral level. Similarly, we can look at the anatomical reference lines, and many of you will be familiar with a neck shaft angle of 130, but we can use a anatomical medial proximal femoral angle. Again, these are measurements that have been measured on hundreds of x-rays by Paley and his team, and so we've got this reference line from a population average. So the anatomical MPFA is a reference line that we can use in certain instances when we haven't got the use of a anatomical axis. And similarly, we've got reference angles for the distal femur and the proximal tibia. So if we're thinking of the mechanical axis, we have an 88-degree lateral distal femoral angle subtended by the long mechanical axis and the femoral condyles. We've got a medial proximal tibial angle, an 87-degree reference angle, which is between the tibial plateau and the tibial shaft. And similarly, we have a set of values at the ankle, pretty much 90 degrees, and we have a set of values which are specific to the anatomical axis. And as you might well appreciate, the anatomical values for the tibia are similar to the mechanical values for the tibia. You will have already realized that the difference between anatomical and mechanical axes is specific to the femur. Okay, so let's just look at some examples of this. So we can see that there is a deformity in the femur here on the far left side, and we've drawn this lateral distal femoral angle at 103 degrees, and it should be population average should be 88 degrees. So there is a deformity here. So to determine the center of the deformity, the apex, the coras, the ACA, we need a reference angle, and the reference angle that we can use in this case is the 81-degree anatomical axis that Paley and his colleagues have described. So we can draw that reference angle here in blue on the far right, and we can keep our proximal anatomical axis, and then we can work out where the two intersect. That is now our apex. that is now a potential cora. That is the point through which the ACA will pass. And so if we were to do a correction, then it would look something like that. Okay. Another example, this time in the tibia. We can look at a deformity of a tibia, and it's obvious that there's varus again. We do our measurements and we can see that there's a deformity in the proximal tibia. So we draw the population mean, which is 87. We draw the distal anatomical axis, and we can see where the two intersect. So where the two intersect, that's our apex. That's one of the coras. That's through which the ACA will pass. We can measure that. That measures 12 degrees. So if you were to do a correction at that apex, it would look something like this, and we would have a perfectly straight mechanical axis after this correction. So that's the basic premise of using these reference angles, these joint orientation angles. What we need to do now is give it a system. And what I would say is that we have to we run a system called if I just go back a sec, we can do the analysis by this system. Map your ABC, and those 6 capitals, MAP, ABC, give you the 6 basic steps for assessing a deformity in the lower limb. M stands for assessing the mechanical axis. A stands for drawing the joint orientation angles, so the reference angles that I've elaborated. P stands for identifying the level at which the deformity is present. So P, pick the bone of interest. A, apex of the deformity. Your reference line and your anatomical axis should give you an apex. Measure it, see how much that measures. B, cut the bone. Where are you going to place your osteotomy is crucial. You can't put your osteotomy right next to the peroneal nerve, for instance. You've got to be careful. In some instances, you can't. Your apex might be very close to the joint, so you have to place it further away. For instance, if you have physeal or joint deformities, your cora will be almost articular, in which case you have to place your osteotomy distal to the apex and undertake osteotomy rule number 2. And finally, once you've done that, you have to have a think about how you're going to stabilize the osteotomy once you've achieved it. Is there enough fixation above and below for a nail, for instance, or are you going to have to use something else like a frame or a locking plate? So here we go. Let's move on to putting the MAP ABC into practice. So the first thing that we start with is the mechanical axis. So you draw your mechanical axis, which is a straight line from the center of the femoral head through to the center of the ankle. Where does that line subtend? Okay, so if your line lies on the outer side of the center of the knee, then you've got valgus. If your line lies on the medial side of the knee, then you've got varus. Bear in mind that occasionally there might be some varus valgus from laxity, especially around the knee ligaments. It's important that soft tissue assessment is made as part of the assessment of deformity analysis, because some of the valgus might be dynamic, i.e. related to collateral ligament laxity in particular. So the mechanical axis, varus and valgus, is generally speaking a radiological measure, with the caveat that it's important to take clinical assessment into consideration. Also consider how congruent the femur and the tibia are. So the angulation between the distal femur and the proximal tibia mustn't be more than 2 degrees, either varus or valgus. 2-degree incongruency is the maximum that's permissible by normal standard. So the first step is to draw the long mechanical axis, the M in our algorithm, MAP, ABC, M for mechanical axis. In this case, we can see that the mechanical axis lies medial to the knee. So we're looking at a varus deformity. Now we have to work out, number one, where is the varus deformity? Is it in the proximal femur? Is it in the distal femur? Is it in the proximal tibia? Is it in the distal tibia? That's the next step we have to do. Then we have to measure it, and we have to work out how much that is. Then we have to work out where can we do our osteotomy, and finally, once we've done our osteotomy, how can we stabilize or fix it? So M for mechanical axis. Let's split the mechanical axis into two separate lines so we can have a femoral mechanical axis. So we can have a femoral mechanical axis and a tibial mechanical axis, and we can use this to now draw our reference lines and to measure each level's orientation angle. So if we use the angles that we talked about previously, so the first angle is the hip line, and as I said before, this measures 90. The normal range is 85 to 95. So in this case, we haven't got a deformity there. Okay, let's do the distal femoral line, and in this case, we can see there's a distal femoral angle of 88 degrees. The population average is 85 to 90. So we haven't got a deformity here either. Let's look at the proximal tibial line. This measures 81 degree. The population average is 85 to 90, indicating that there is a deformity in the proximal tibia. Let's quickly check the distal tibia. So we can do a distal tibial line, and that measures 90. And the population mean is 86 to 92. So it's within that range. So we have a varus deformity. And what we can say is that the varus deformity is because of a deformity in the proximal tibia. The proximal tibia. And this might be, for instance, something that you might get with osteoarthritis, with medial compartment osteoarthritis, when you get varus, and you might consider a high tibial osteotomy. So this would be that kind of clinical scenario. Okay, so once we've worked out what the bone of interest, i.e. P, the bone of interest, we have to now focus in on the proximal tibia. We have to work out where is the apex of the deformity, where are the coras, where's the acca, where can we do an osteotomy safely? So now, as I mentioned before, this is where we need the reference angles. So let's scrub out all these lines, and let's just keep the line of interest, which is the proximal tibial line. And we know from population average that we should have an MPTA angle of 87 degrees, which I've drawn there. And when we bisect that with the anatomical axis of the tibia, we can see that the apex is right next to the joint. It's a periarticular deformity. The coras are really high up. The axis of correction is really high up. So as you know, you won't be able to do an osteotomy at that level. You're going to have to do your osteotomy in a different place. You're going to have to do your osteotomy in the metaphysis, like so. And when you do your osteotomy at that level, then that leaves you enough space to fix it with a frame or a locking plate. Immediately, you know, this is not something that you can treat with an intramedullary nail. And once we do our cut at this level, if we are able to, this will be osteotomy rule number 2. We will have to do a little bit of translation, but we end up with a straight anatomical axis. So the femur, knee, and ankle all in a straight line. So this is osteotomy rule number 2. Well, there was a lot of detail in that section, workshop station 2, and I hope you understand this algorithm that I'm trying to give you. Assess the mechanical axis, understand the joints the angles for joint orientation. Once you work out angles for joint orientation, you should be able to draw lines which then give you an apex, which give you multiple coras, which give you an acca, and then allows you to then cut the bone at a safe level and then plan where you can do your fixation. So I hope that system MAP ABC will be of use to you. Okay, if you're watching this video, I'd suggest you stop it here, take 5 minutes, revise the material, and then come back to do the next section of the workshop station, which is our last section, where we will do some examples for deformity planning. Okay, so I've got some diagram cases and some real cases. So I'm going to switch from my PowerPoint show to a normal view so that I can just run these cases for you. I just need to take them out. Okay, so let's start off with a mechanical axis. So let's draw the mechanical axis first. And as you will recall, the mechanical axis is a straight line from the center of the femoral head to the center of the plafond. And you can see this is grossly in varus, isn't it? So we'll draw an angle for, we'll draw an anatomical axis for the femur, sorry, a mechanical axis for the femur. We'll draw a mechanical anatomical axis for the tibia. And now let's just quickly do the lines at the different levels to see where the deformity lies. Does the deformity lie in the proximal femur, the distal femur, proximal tibia, or distal tibia? So we'll draw our hip line first. I'll just rearrange that line slightly. Okay, so there's the angle for the proximal femur. You can see it's very slightly in valgus, so it should be about 90, and you can see it's measuring 93. Okay, let's put that away. Let's look at the distal femur. So the distal femur, I haven't got an online protractor with me, but I have measured these angles before. And the lateral distal femoral angle measures 89 in this case. And as I told you previously, 88 is the population average, so that is pretty normal too. Let's look at the proximal tibia. And when we draw a proximal tibial line, you can see that this angle, this angle here measures 47 degrees. Okay, 47 degrees is abnormal. That angle should measure 87 degrees. Okay, so let's scrub that for a sec. So we know that there's a difference in the proximal tibia, just worth checking the distal tibia while we're at it. And I've measured this previously and it measured 90. So we know there's no deformity in the distal tibia. So we're left with a deformity in the proximal tibia, which we now have to analyze further. So what do we do next? Well, we've got our distal anatomical axis in the tibia. What we need to do is draw the population average, the reference line angle of the proximal tibia, which is the 87 degree angle, which I told you about previously. So we have to draw the 87 degree angle. And I know, having done this previously, that that is the 87 degree angle there from the proximal tibia going down into what should be the correct anatomical axis. So my anatomical axis that exists subtends my reference angle right at the physis. And as I told you previously, these are this kind of deformities that arise with severe congenital deformities, for instance, a growth plate arrest at a young age, for instance, or Blount's or something like that. So this is that kind of scenario. So now we're left with an angle which we have to assess. This is the A. So the A is right there at the physis. And we have to now measure that, so we can do that. And I've done this previously. That measures 36 degrees, that angle there. So we have to do a correction of the proximal tibia of 37 degrees, and now we have to place our osteotomy. So just have a think for a second, where would you place your osteotomy? You know, the osteotomy, the highest you can put your osteotomy is at that intersection, the apex there. But in practice, you'll probably put your osteotomy at the metaphyseal diaphyseal junction, somewhere like that. That would be the practical place to put that osteotomy, because that then allows you to fix the proximal and the distal sufficiently with either locking plate or frame, whatever's your choice. But you can see immediately that this is not something that's suitable for an intramedullary nail. So just to make the point, I will just show you how that would work. So we would be able to get that kind of correction by getting an osteotomy, an opening wedge, gradual correction with a frame, and we'd get a straight mechanical axis and restoration of the femur, the knee, and the ankle, all in the same line. Okay, I hope that makes sense. Let's move on to another case. This is a real life case of a girl who presented with severe genu valgus. So let's do those sequences, that sequence again, MAP, ABC. So let's just do that M first, M for mechanical axis, center of femur to center of ankle. You can see it's in severe valgus. And the severe valgus means that there is a deformity at one of these levels, distal femur or proximal tibia. So we have to do the same measurements that we've done previously. Let's make an anatomical axis at this level here. Sorry, do a mechanical axis for the femur, mechanical axis for the tibia, and let's do the angles of joint orientation, which I mentioned to you previously, angles of joint orientation. So the A of our algorithm, we've done the M, we're on to the A. So again, we do our proximal femoral angle, and proximal femoral angle, I've measured this previously. This is 90, that's within the population norm. Let's do our distal femur. Distal femur measures 72. Okay, so that's abnormal. Population average should be 88. Let's do the proximal tibia. Population average should be 89, and that's measured. It should be 87. It's measuring 89, so not too bad, within the normal range. Distal tibial angle, mentioned that previously, should be 90 degrees. Yeah, so that's the angle there, and that would measure 90 degrees. So that's within the average population range. So we're left with a deformity of the distal femur, and that's this angle here. So now we have to draw an apex, and we would draw the apex by, first of all, drawing an anatomical angle axis. So let's draw the proximal femoral anatomical axis. Now we have to draw a reference line, and we would draw the reference line with the distal lateral distal femoral angle, and I've drawn one here already, so I'll just bring it into place here. Just magnify it a little bit so you can see a bit more clearly, and you can see how the distal femoral condyles form this 81-degree reference angle, and in this case they intersect with the proximal anatomical axis in the metaphyseal zone, just below the diaphysis, and you can see that's where the apex would be. So when we have to measure our deformity, then we have to measure the deformity between our reference line and the anatomical axis. That would be our deformity there. Okay, so I've measured this previously. This measured 20 degrees. So now we have to make ourselves an osteotomy. Now, an osteotomy as you worked out, as we mentioned before, if you do an osteotomy at the level of the intersection, at the level of the apex, there is no rotation. If you make your osteotomy a little bit distal, then you have to dial in a little bit of rotation. So in most cases, we would be able to do our osteotomy at this level. That shouldn't be impossible, and potentially you could then have enough space above and below to fix it with a nail if you wish, either antegrade or a retrograde nail, or potentially a frame, or potentially a locking plate, your choice. So this would be one that would lend itself to all three. So let's look at what it would look like if we put our femur at that level with a 20-degree rotation, with a 20-degree angulation correction. So we would put our femur like that. Let's zoom out a little bit. And now when we do our mechanical axis, bingo, almost not completely through the center of the knee, but a whole lot better than it was previously. So the mechanical axis previously was outside the knee, and now it's just lateral to the notch, probably at what's called a Fujisawa point, which is 2/3 from medial to lateral, which is a safe place to be anyway. So that would be an example of MAP ABC, drawing the mechanical axis, drawing the orientation angles, finding where your deformity is. In this case, the deformity was here at the LDFA. We've drawn the apex by drawing a reference angle along with our anatomical axis. We've put our osteotomy, and we've talked a little bit about how we would stabilize it. Okay, maybe another couple of examples. So here again is a child with a deformity, quite severe varus. As you can see, the mechanical axis has already been drawn. It's lying medial. So there's a varus deformity. We have to work out if the varus deformity is in the proximal femur, the distal femur, proximal tibia, or distal tibia. So let's just work through the possibilities. And what we'll do is we'll first of all draw the femoral mechanical axis. So we're doing the A part now with angles of orientation. So the proximal femoral angle would be that one there. And I can tell you I've measured this already. This is 93. So that's a little bit higher, but not severe enough to account for any deformity. Let's put that away. Let's look at the distal femur. Just zoom in a little bit. Okay, and when I measured that previously, that was pretty much 89. So that again is within the normal range. Let's look at the MPTA. So we have to take our mechanical axis and place the other way. And I've measured this previously as being 47, so there's an abnormality there. Distal tibia, and that's 90, so there's no deformity there. So our deformity is in the proximal tibia from what I've measured previously. So what we need to do is draw our now determine where our apex is. So if we draw a angle of or do our distal anatomical axis, we do our reference angle. So the intersection of the two will be where the apex is. And again, as you can see, the apex is very proximal. So in this case, again, you wouldn't be able to put your osteotomy at the level of the apex. You would put it a bit further away, allows you to fix with a plate or a frame. And again, as you just do the correction, you'd be able to get a perfect anatomical axis. Okay, and one final example. Let's do the anatomical axis again, the M part of our algorithm. So we draw the mechanical axis, and we draw a proximal femoral angle, and you can see it's in valgus in this case, but again, not severe enough that it should be a whole lot of a problem. So we'll discard the proximal femoral angle. Let's look at the distal femur angle, measured 89 degrees, again, not severe. Measure the proximal tibial angle. And in this case, it measured 47, which is severe. And the distal tibia angle, I can tell you previously measured was 90, which is within the population range. Okay, so the deformities in the proximal tibia, we need our reference angle, so which is 87 degrees. We do our proximal tibial line. We do our reference line, and you can see where they intersect. That's where the deformity is. That's where the apex is. Again, too close to the joint to do your correction at that level. So you're going to have to do osteotomy rule number 2, which is something like that. Just take some of these diagrams away. And you'd be able to do your osteotomy and correct it like that. So again, testing your hypothesis with a straight mechanical axis, you can see center of knee, center of ankle, center of hip, all in the straight line. So that's the way that we would be able to correct and analyze and correct most deformities using that 6-step method. So that was a lot of work. I hope you were able to follow most of that. Obviously, the advantage of the video is that you can stop, you can replay it back, and do keep posting comments or questions. I'd be very happy to answer them if you wish. I'll also be very happy to send you a PowerPoint with these worksheet examples if you want to send me your email or post your email in the chat. Thank you very much for listening. Just to summarize, we've covered the basics of deformity analysis in the coronal plane, the mechanical axis versus anatomical axis, the apex, the chora, the ACA, and the osteotomy rules. We've talked about the technique or the algorithm for assessing deformity, which is MAP your ABC, map your ABC. It's a 6-step method of determining the mechanical axis, drawing your joint orientation angles, determining where the apex is, and ABC, find the apex, cut the bone, and then decide what's the best way of stabilization, fixation. And we try to use that with some cases. So just to say that, limb deformity analysis is about the bigger picture. It's not just about focusing on the ankle or the knee or the hip. It's looking at the whole limb in its entirety and making sure that the patient gets best function out of it by aligning the 3 joints in the orientation that they were meant to work at perfectly. It's a system, not a technique. Thank you very much for listening.
Thank you, Alvin, for yet another brilliant talk and very beautifully explained. A couple of questions from our side.
Sure. Yeah.
Okay, so you mentioned about osteotomy 1 and 2 were very clear, and you said osteotomy rule 3 is probably a misnomer. Are there any clinical applications for that? Is there a scenario where you're going to, because 1 and 2 is very clear.
Yeah. To be honest, no, there aren't really any applications. It's more of a reminder that if you don't appreciate 1 and 2, you will create a mistake by undertaking 3. I can't think of any scenario where you would actually deliberately misalign anatomical axis of the femur with the anatomical axis of the tibia. I honestly can't think of any scenario when you would do that.
And by saying that, it reaffirms the statement that the ACA should be exactly at the cora. Am I right? At whatever scenario it is.
Yeah. So I in my talk, I preferred to use the word apex, because cora is actually, apex is 1 point. It's where two lines meet. There's only 1 point. That's the apex. Cora is any line on the ACA. And as I said, if you choose a cora on the convex side, then you will get an opening wedge. And if you choose a cora on the concave side, you will get a closing wedge. You will get shortening. So that's the kind of practicalities of the ACA, allowing you to determine where you want your cora. So for instance, if you want to correct an angle and you want to get length at the same time, so if the leg is crooked and short, then you put your hinge way off on the convex side and you will get lengthening. And conversely, if you have a deformity and you want shortening, so for instance, I don't know, the soft tissue issues or a contracture and you're trying to overcome that, then you'd put your cora on the concave side to shorten it, to then try and overcome the contracture and the joint stiffness associated. Yeah.
Thank you, Alvin, for that. The other concern or a question would be with regards to high tibial osteotomy. I mean, that's a very common procedure. And in that, we follow the rule too, right? Because again, you mentioned about Fujisawa point. There was some confusion about Fujisawa and where do you put the correction in a high tibial osteotomy?
Okay, well, should we try and go back to that case? That might help. How about we use this example again, Hitesh, because this is like an extreme version of varus, right? Oops. Sorry, I'm making a mess of this.
It's going to be a lot of work for you.
No. So here we go.
Okay.
So you can see that diagram, can't you?
Yeah.
Yeah. So should we say that this is like an extreme version of varus? So as I said previously, so as I said previously, the first step of deformity analysis is to draw a mechanical axis. Yeah. And what you want is for this axis to go through the center of the knee, and then finally at the end of your correction, you want it to go through the center of the ankle and the center of the knee. So if you like, if you want it might be easier to use this blue line. No, I can't use a blue line. It might be easier to say that if you had a mechanical axis of the tibia like that, then you want to have a femoral axis and the mechanical axis ending up collinear. Yeah, that would be the ideal scenario. You want it to end up like that. Currently we are here. Yeah. So when we do our analysis, we can see that the apex, the intersection point, is at that level. Unfortunately, in this case, we can probably do an osteotomy here. But imagine if the apex was higher, then we would be unable to do it at the level of intersection or the apex. We would have to do it at a slightly distant point for safety, to prevent injury to the peroneal nerve. And also just practically, it's almost impossible to cut across the tibial condyles. It's much easier to do it much more distally in the upper shaft. So in this case, we could use that point. And what we would do then is that we will, and I'm bringing a spare tibia here, is that we would then rotate it at that point there to get that type of correction. And because we are choosing an osteotomy at levels slightly distal to our apex, then you would find on an X-ray that the cortices are slightly translated to allow you to do that. I don't know, does that answer the question, Hitesh?
Yeah, so it comes under osteotomy rule 2, right?
Yes, exactly. Yeah.
Yeah, that's a question. Perfect.
It'd be very rare that osteotomy rule number 1 allows you to get your correction. I guess in some instances with HTO, if your apex is very close, if you can get your osteotomy very close to your apex, then you might be able to do it by osteotomy rule number 1. So in a high tibial osteotomy, your apex will be very close to the joint. But if you can do your osteotomy through it, and I don't do high tibial osteotomies, but your cut is a very oblique cut, isn't it? It's from the medial cortex to the proximal tibiofibular joint. And in that case, your cut might be very close or through the apex, in which case you can say, I don't need to translate. This is now osteotomy rule number 1.
Thank you, Alvin, for that. Just one last question. I mean, we have a lot of residents and fellows with a global representation on our channel. And personally, I've attended 2 Ilizarov courses, one for a deformity correction and for 3 days. What happens is after the course, all this stays for a month, then you tend to forget over a period of time. So what do you recommend for a resident who is watching it to practice? Okay, 3 most important deformities. And you've shown a lot of animations. You've used Microsoft, I think, for your presentation for the animations. A lot of, I mean, I've hosted a couple of guys who have used a computer software to learn these deformities. So a resident perspective, watching from a different part of the world, what is your learning method that you suggest?
Okay, so I would say learn the algorithm that I try to emphasize. Learn MAP ABC. You know, and to be honest, if you follow those 6 steps, I think it does become easy. Emphasizing the importance of the mechanical axis. So we should all appreciate mechanical axis, you know, whether you're nailing a femur, whether you're nailing a tibia, you should have an appreciation of mechanical axis, even with these very common operations, which are non-deformity operations. You should have a appreciation of that. It's very common, for instance, with a distal femoral plating, for instance, very common for a distal femoral plating after a fracture for it to be nailed in varus, very common. And, you know, you need to have an appreciation of anatomical axis, mechanical axis for these simple trauma cases. So I would say learn this 6-step algorithm. And it's by no means my own. I've heard other people use it, and I think it makes very good sense. Appreciate the M for mechanical axis. You have to learn how to draw the joint orientation angles. I'm afraid there's no other way apart from saying, you know, learn these 6 lines. I don't think they are very difficult lines. They're very simple lines. You know, when you do a hemiarthroplasty, which is a very common resident operation for proximal intercapsular hip fracture, you should appreciate the proximal femoral line, because the center of the hip should be at the same level as the tip of the trochanter. And if your hemiarthroplasty is too high or too low, you will get a deformity. So that's an example of an angle of joint orientation, but you have to learn these lines. Every time you look at an ankle x-ray, it should just look so obvious that there's a 90-degree angle of the plafond to the shaft, you know, and that is another example of reminding yourself about the joint orientation line of the distal femur and proximal tibia. Your questioner will not be unique. There are so many you know, delegates who've been on courses and forgotten these, but I think you just have to learn these 4 lines and practice drawing your mechanical axis. Once you learn these angles, then I think it becomes much easier to appreciate, you know, when 2 lines intersect, you get an angle. Yeah, when 2 lines intersect, you get a deformity. That's your apex, that's your cora. Now, can you cut it at the cora, or do you have to do it more safely at a slightly distal place? And then that leads you on to rule number 1, rule number 2. So I think just learning those 6-step method is straightforward, and there's a, you know, it will be on your website, on your YouTube channel, for instance, and there will be other links. Our own website, our own YouTube channel, Leicester Orthopaedics, which has something very similar. So yeah, I hope that helps.
Thank you, Alvin. I think that's all the questions that we have for this session, Alvin. Thank you for yet another fantastic lecture. And I'm sure this is going to benefit a lot of people all over the world. Thank you so much for joining in.